Welcome back to Gastroenterology and the wonderful world of GI bleeding. The first and most important thing about gastrointestinal bleeding is the subject of fluid resuscitation. Now, I know you think it's etiology, but it's not the etiology. It's based on the severity. It's not the etiology. It's based on the severity. So you got a 72-year-old guy with a history of aortic stenosis. And this 72-year-old guy with a history of aortic stenosis comes to the emergency department with red-black stool over the last day or two. And this red-black stool over the past day or two comes in with red-black stool the last day or two. His blood pressure is 94/60 and his pulse is 105. The guy comes to the emergency department and the pulse is above 100. The systolic blood pressure is 94, 105, 110, 112. Doesn't matter. Systolic at 94, systolic at 96. Doesn't matter. 92, 94, 96. And red black stool 5 times, 4 times, 6 times. Doesn't matter. Close enough for government work, is to say. I am so predictable. What's the next best step in the management of this relationship? What's the next best step in the management of this patient? The wrong answer is to say endoscopy. The wrong answer is to say NG tube. Endoscopy should be done, but it's not first. Nasogastric tube. This is one of the only patients in whom it might be useful, but you can see that we got a lot of room here. And nasogastric tube is not first. Nasogastric tube is not first because the major point of nasogastric tube is to determine, do you do scoping from above first, or do you scope lower first? The nasogastric tube is one of the least useful things. Now, I know that other people told you it's the most useful, and I know that other people said slip them the tube first, but nasogastric tube is always less important than fluid resuscitation. Bolusing this person with either normal saline or Ringer's lactate is far more important than nasogastric tube. If somebody else says nasogastric tube, you should question them. You mean after the fluid resuscitation, right? Oh no, he told us nasogastric. Excuse me, what did I tell you? You mean after the fluid resuscitation, right? And then they'll say, you're right, after the fluid resuscitation. It's good to put in the nasogastric tube. It's good to put the tube in. But if you skip certain steps and you go straight to the tube and do it first, then it won't be special. So you should always do a few things first. Buy them a drink. Test out the waters. CBC, bolus of fluids, before we go straight for the tube. Oh, hose monsters out there. So therefore, fluids, blood, bolus of saline and Ringer's lactate. CBC, you're looking for 2 things, the hematocrit and the platelet count. And you're looking for the hematocrit and the platelet counts because if the hematocrit is low, if you're an older guy like this with a history of aortic stenosis, people above 60, people with heart disease, they should get transfused when the hematocrit is less than 30. You should get a unit of packed red blood cells. Packed red blood cells. If you're younger, healthy, 27-year-old video guy, let him get a hematocrit of 25 or 20. Why put another pint of blood into him? He'll make his own blood cells. Motorcycle accident, gets cut, gets beaten up, girlfriend stabs him in the neck. Then you let his hematocrit go down to 20 or 25 because he'll make his own blood cells over a couple of days. Old guys with heart disease, keep that hematocrit high. Younger people with no heart disease, let the hematocrit go under 25 for sure. And the reason is that the oxygen delivery to tissues, is a function of three things. One, how much blood, hemoglobin, hematocrit. Now, whichever one you like to work in, it doesn't matter, because for every 3 of hematocrit, there's 1 of hemoglobin. So whatever you want to do, as long as you remember there's a relationship of 1 to 3, it doesn't matter, whichever one you're used to working in. The hemoglobin or the hematocrit times the cardiac output. In other words, you got this amount of blood, but how much of it are you moving per minute with that cardiac output? Maybe you got a hematocrit of 70, but your heart's beating like this. Kaboom. Kaboom. Why, then you're not moving much oxygen forward, are you? Well, if you have a high hematocrit, but you're not moving any oxygen forward because the cardiac output is poor, well, then you're not delivering any oxygen. Listen, I might have trucks that are packed with food, but if I'm only delivering 1 truck a week, I am not delivering a lot of food. It's the same concept, times the percentage saturation. It's no different than trucking business. How many trucks you got, how often are you sending those trucks out, and how filled up are the trucks? It's no different than looking at the trucking business or the shipping business. How many ships, how fast do you send them out, and how filled are they? When you have anemia and you have a markedly decreased hematocrit, you have decreased your oxygen delivery. And that's why the person who's an older guy, who's got a history of heart disease, is much more vulnerable to decreases in oxygen delivery. The guy who's the older guy, heart disease, is much more vulnerable because he can't handle the decrease in oxygen delivery. Now, the platelet count less than... we should transfuse platelets. A platelet count less than... The platelet count less than... I bet some of you are thinking 20,000. I was once young and foolish like you, and I thought it was 20,000 also. But 20,000 is the number for when you become at risk of spontaneous bleeding. That's when you become at risk of spontaneous bleeding. So spontaneous bleeding develops at under 20. When you're actually bleeding, you don't transfuse unless the platelet count goes under 50,000. When the platelet count goes under 50,000, that's when you transfuse, when you're one of two things. Gonna undergo surgery, I'm gonna cut you, or you're already bleeding. I don't have to cut you, you're already bleeding. So when the platelet count is low, then you transfuse when you're gonna get cut or you're already bleeding. Old guy, give him a lot of hemoglobin. He needs a lot of oxygen carrying capacity because his heart's going to die if you don't. Now, platelets, if the platelet count is low, low if you're bleeding and low if you're surgery, is 50,000. Now, what should everybody get? A prothrombin time, the PT. If the platelet count is down, you're going to get platelets. If the prothrombin time is elevated, you're going to give fresh frozen plasma. If the prothrombin time is up, you're going to give fresh frozen plasma. And why are you going to give fresh frozen plasma? Because it works instantaneously. The fresh frozen plasma works right away. Vitamin K takes time. That's why we're not going to give vitamin K right away, because vitamin K takes time. So, therefore, fresh frozen plasma works instantly. Vitamin K takes time. Now, fluids, blood, platelets, plasma, fluids, blood, platelets, plasma, fluids, blood, platelets, plasma is far more important than knowing etiology. In other words, if this person needs upper endoscopy, and this person has an upper gastrointestinal bleeding, the most common cause for severe upper GI bleeding is ulcers. Gastritis, ulcers is number one. The most common cause of significant upper GI bleeding is ulcers, but it can also be esophagitis, duodenitis, gastritis, Mallory Weiss. It can be any one of these. Meckel's diverticulum, esophagitis, gastritis, duodenitis. Now, although I would like to know the etiology of the GI bleeding, and you would like to know the etiology of the GI bleeding, we'd all like to know the etiology of the GI bleeding. However, it doesn't change acute management because fluids, blood, platelets, plasma, fluids, blood, and platelets, plasma doesn't change in any of these. If you have gastritis with bleeding you down to a hematocrit of 20 and you have platelet count that's low, you're going to give fluids, blood, and platelets and plasma. And whether it's lower GI bleeding, whether or not it's number one cause, diverticuli, RIV malformations, also known as angiodysplasia, dysplastic blood vessels, evil blood vessels, or whether it is inflammatory bowel disease, or whether it is cancer, with these two things being number one, it doesn't change the acute management. Fluid, blood, platelet, plasma is more important than etiology. Why? Because you're not going to die today of whether or not it's gastritis or whether it's Helicobacter pylori. You'll die today if your heart does not have enough oxygen carrying capacity. Oxygen carrying capacity is everything. You want to give the blood. You want to give the fluids. When someone shows you a scope, you say, I want to give the fluids. I want to give the fluids. You want to give fluids. You want to give blood. You want to give platelets. You want to give plasma. You can always put the tube in later. The point of the nasogastric tube is to see whether that black stool might be from an upper GI source. This case is specifically geared to make sure you understand that fluids, blood, platelet, plasma is more important than specific etiology. Now, why are orthostatic blood pressure measurements not useful in this guy? Orthostasis is a nice thing. In other words, orthostasis. I have a greater than 10 change in pulse between lying down and standing up. My pulse goes up. Well, everybody's pulse goes up. When they go from lying down to standing up, everybody's pulse goes up. Mine does too. Yours does too. But I have an autonomic nervous system. And my autonomic nervous system will correct that pulse in 1 minute. So although when I go from lying down, lying down to standing up, my pulse will go up, but it won't go up 30 points, and it will come down in a minute. When you are volume or fluid depleted, your pulse goes up and it stays up. And that's the difference. A greater than 10 change in pulse, a greater than 20 change in systolic blood pressure. From lying down to standing up, everybody's blood pressure drops when you stand up. However, it shouldn't drop 25 and 30 points. The other thing is, it should correct itself within a minute. Orthostasis implies a 15 to 20% blood or volume loss. It is not useful in this person. First of all, if you stand him up and he drops his blood pressure into the 70s, you may kill him. So that doesn't help you. The second thing is orthostasis is to detect small amounts of blood loss in people who have normal blood pressures on standing and lying down. They are to detect small volume loss in people who have a normal blood pressure, and then you stand them up and the blood pressure drops. Once you have a systolic blood pressure less than 100 or a pulse greater than 100, you already know that you have a 30% volume loss. Therefore, taking orthostatics doesn't help because we already know we have a major loss. One, standing this guy up, let's say like this. Little old man, you stand him up, blood pressure drops into the 70s. Whoa, way, yep. And he has syncope. Why? Because if you got this pulse and blood pressure lying down, he might fall over when you stand him up. So it says orthostasis is for people who are normal when they're lying down. Then you stand them up and they drop down. That's the point. Okay, so fluids, blood, platelet, plasma, nasogastric tube might be useful in this guy. Why? Because 10% of significant lower GI bleed, red blood like this, 10% of people who have red blood are really an upper GI source. Okay, it's an upper GI source. What would we do differently? It's an upper GI source. What would we do differently? Well, if it's an upper GI source, you can cauterize the ulcer. If it's an upper GI source, if that is the case, you can cauterize the ulcer. If it's an upper GI source, you can inject epinephrine. You can cauterize the upper GI source. You can clip, band. If it's ulcers, gastritis, Mallory-Weiss tears. There's also one other thing you would do different if it was ulcer and gastritis. Ulcers and gastritis would get treated with something else if it was a person who had ulcer and gastritis, and the answer is not Helicobacter pylori acutely. The answer is that what you would do different if this was ulcer and gastritis, not treating Helicobacter pylori, not acutely, but proton pump inhibitors. If this was ulcer and gastritis, if you gave a proton pump inhibitor, you could help control acute GI bleeding. With a proton pump inhibitor, you could help control acute GI bleeding with that proton pump inhibitor. You can help control that acute GI bleeding. So H2 blockers, that will be the wrong answer. Ranitidine, famotidine, nizatidine, cimetidine, sulcrafate. They won't do anything for acute bleeding, but proton pump inhibitors will. What would you do differently if this was diverticuli and AV malformations? The answer is cauterize, epinephrine, not very much. You wouldn't do very much different. For ulcer disease and gastritis, esophagitis, proton pump inhibitors. For acute bleeding, you could cauterize or clip. Orthostasis is for people who have normal pulse and blood pressure lying down, and to see if it becomes abnormal when standing up. That is why nasogastric tubes and endoscopy are not as useful as giving fluid, blood, platelet, plasma, because if you don't scope them, you just give them fluid, blood, and platelet plasma, 80% of the bleeds will stop anyway. 80, like 80% will stop anyway. So therefore, even though you don't scope, 80% will stop anyway without the scope. If you do scope, but don't give fluids, blood, platelet, plasma, that means 80% won't stop. Boy, oh boy, then we're really intercoursed, aren't we? So therefore, you have to give the fluid resuscitation first more than the endoscopy. Thought they were going to stop me there. All right? Fluid resuscitation more than the endoscopy. Now, if the person says he has a history of alcoholism or liver disease, if there's alcoholism or liver disease, what will you do differently in this guy? If there's alcoholism or liver disease, what are you going to do differently in the management of this patient because of the presence of alcoholism or liver disease? What is the difference or alterations in the therapy based on the presence of alcoholism and liver disease? And the answer is, particularly if they are vomiting blood, there is something that gets added. Number one, if you're vomiting blood, you don't need to do nasogastric tubes, because the one thing about vomiting blood, you know for sure it's an upper GI source. Liver disease, cirrhosis, vomiting blood. What are we going to do differently? And the answer is we're going to add octreotide. We're going to add octreotide. And why are we going to add octreotide? We're going to add octreotide because that's what you do for varices. Octreotide decreases portal pressure. So octreotide is added for all people with variceal bleeds. Why? Because it decreases portal hypertension. So octreotide is added for all the patients who seem to have variceal bleeds from portal hypertension. How will you know that? Liver disease, alcoholism, vomiting blood. Overall, the form of GI bleeding as a single cause that has the single greatest mortality is the bleeding of esophageal varices. So bleeding of esophageal varices has the single highest mortality per episode. Octreotide lowers mortality. The same thing is in play. I cannot emphasize it enough. Resuscitation with fluids is far more important than determining a specific diagnosis. Infinitely more. Wouldn't you rather be alive with no specific diagnosis than dead with a specific diagnosis? Well, your husband died of variceal bleeds. What happened? He died. He died? Yeah, well, what are you worried about? We got a specific diagnosis. I'd rather be alive with no diagnosis than dead with a specific diagnosis. Now, the other thing that should be done as well in patients who have this severe bleeding is a diagnostic test should be done as well in all patients, particularly this older guy. How do you die of acute GI bleeding? How do you die today? Anemia. Yeah, well, how do you die? Low hematocrit. Well, that's like saying anemia. Well, decreased red cells. Well, that's like saying, what's the number one cause of poverty? And you say, no money. Well, the number one cause of death is to get an EKG. Getting an EKG causes death? No! Getting an EKG shows that your head is not in the splenic flexure of your own colon. It shows that you know, how do we die? And step 2 will like that. You know, step 2 is not going to be as interested that you know the difference in the management of Meckel's diverticulum versus Mallory-Weiss. Because for the first hour, they should all get 2 large bore IVs with a ton of fluids. You should check the CBC to see whether they need blood, platelets, and check a prothrombin time to see whether or not they need fresh frozen plasma. If you have a person with GI bleeding and you have a computer program or a chimpanzee that gives fluids, blood, platelets, and plasma, a computer program will do much better than the average human being. Why? Because the computer doesn't have to remember to check the hematocrit, remember to check the results, and remember to give a new unit of packed red blood cells. Now, packed red blood cells are the treatment for all forms of major bleeding. When do we use whole blood? When do we use whole blood? Well, you might be saying never. Well, I never use whole blood, but maybe you do. You don't either? Well, that's a good thing, because whole blood is... Reporting to you from Arlington National Cemetery, whole blood was laid to rest today in the tomb of the unknown medical therapy, along with chloramphenicol, griseofulvin, and the CT myelogram. Whole blood is archaeologic. You either give packed cells or fresh frozen plasma. How do you die? Of ischemia. Why? Because your left ventricle cannot distinguish between anemia, congestive failure and decreased cardiac output, or decreased saturation of the oxygen. So your left ventricle cannot distinguish between those things. So how you die of anemia is you die of ischemia. The myocardium can't distinguish between carbon monoxide poisoning, anemia, a stenosis in the coronary artery, or decreased saturation. All the myocytes in the ventricle know is they're not getting enough oxygen. Why are they not getting enough oxygen? They can't figure it out. They just know we're not getting enough oxygen. But they can't be precise on it. So EKG shows you know how people die. I know how people die. But do you know how people die? Ischemia today. Now, back to our friend the varicose bleeder. He got fluid, blood, platelet, plasma. Remember, you add this up front for varicose bleeders. Everybody for varicose bleeders. Now, if it continues, if the bleeding continues, what do we do next? Not a Blakemore tube. Not surgery. If you have varicose bleeds not responsive to octreotide, what you do next is you do endoscopy. And you do endoscopy for banding. You mean like rubber banding? You mean like a rubber band, like a rubber band, like a rubber band, like everybody can have a rubber band? You mean you take the varice and you put a rubber band on it and it stops it shut? No. No way. It can't be that simple. No way. Yes way. No way. Yes way. A rubber band on your esophageal varice. Yeah, wait till we catch your hemorrhoids. We're going to do the same thing. Banding is much better than sclerosing. And if you are used to thinking of sclerosing, take everywhere in your brain that search out, find sclerosing, block, delete, replace with banding. Banding has the same efficacy but less side effects. Banding has the same efficacy but less adverse effects. So therefore, rubber banding is superior to sclerosing. Rubber banding is superior to sclerosing. Okay? Now that requires endoscopy. However, if your initial management doesn't work, then you do endoscopy for banding. And that should stop most of it. Uh-oh. 2% of the time, 3% of the time, I did fluids, blood, platelets, plasma. I did banding. Uh-oh. And it continues. Uh-oh. This should stop a lot of people. The people who don't get stopped with this get banded. Rubber bands around my varices acutely. A very small amount. Very teeny little amount. Un po seulement. Только немного. Un poquito solamente. Continue to bleed despite the banding. Now you may say, what do I do next? I bet you want to put one of those Blakemore tubes in. Tamponade tubes. Disgusting. You bleed to death and it just makes you look ugly. Terrible. Surgery? No, Not the yet. Surgery is a dog. Surgery killed 50 to 70% of patients just by cutting them. The bleeding continues. You do TIPS, transjugular intrahepatic portosystemic shunting. Here's the jugular, here's our friend the heart. That's a heart, left ventricle, right ventricle, left atrium, yeah, whatever. Okay, here's that other thing going into your arm. Here's the superior vena cava. And the superior vena cava, and I have to forgive my drawings, I'm more autistic than I am artistic. And here's our hepatic vein. And our hepatic vein, why is the liver on that side? Shut up, don't ask me. Okay, so the thing is, here's our liver, and here's our portal circulation. And our portal circulation, portal vein here, portal vein is made up of the splenic vein. Just be grateful I got the spleen on the correct side. Okay? And the superior mesenteric vein. Superior mesenteric vein, splenic vein. The point is that you go transjugular, down the internal jugular, down into the vena cava, hepatic vein, and ready? Why surgically place a shunt into someone when you can go transjugular, intrahepatic, portal to systemic shunt? Hepatic vein, portal vein, hepatic vein, portal vein? Why do this surgically when you can with fluoroscopy go, poke, and poke a hole through that liver? How do you do this? You poke a hole through that liver, and it will make the blood go up the right way. I can now, with a catheter, a strong right arm, and fluoroscopy. There is no part of your body that I cannot reach. With a strong right arm, fluoroscopy, and catheter. Boom. Why do I need to do surgery when I can just poke holes in your liver with a catheter procedure? This is like being stuck on a highway somewhere, and you have a machine that can come by and instantly lay down 2 lines of traffic, instantly on a roadway. And it puts a 6 or an 8 millimeter pathway through that liver and immediately decompresses the portal circulation. It immediately decompresses the portal circulation. So what ends up happening here is that the blood will now rush out the other way and decompresses the portal circulation. So the management of portal hypertension. The management of portal hypertension is to try to lower it with octreotide. Most people will get better with just this. If it continues acutely, you go on to banding. If it continues acutely, transjugular intrahepatic portosystemic shunting replaces the concept of the Blakemore tube and replaces the concept of surgical shunting. Blakemore tubes and surgical shunting are part of the past, not necessary to do. The major complication of this form of shunting is hepatic encephalopathy. Because although I don't want you to bleed to death from portal hypertension, the blood going through the liver did detoxify that blood. And the good thing about detoxifying the blood is that it prevented encephalopathy. So yes, I've got some good news and some bad news. The good news is that TIPS, transjugular, intrahepatic, portosystemic shunting, basically with a catheter, a strong right arm, and 20 minutes, can create a shunt that used to require 6 hours to 12 hours of surgery and gave a 70% mortality just by the surgical procedure. So it takes that people and basically puts a hole in the liver that decompresses it. The bad news is it causes encephalopathy because now your blood is not being cleaned. Let's say that your filter on your air conditioner at home is clogged up and no air is blowing through. I can go with a pair of scissors and cut a hole in the filter in your air conditioner, but the problem is that the air will blow through, but it's not being filtered anymore. So it may blow through, but it's not being filtered anymore. Now, when are we going to answer propranolol, nadolol, or nadolol? when are we going to answer doing beta blockers? And the answer is we're going to give beta blockers when people have gotten better and have been stabilized. We're going to use beta blockers when people are better and they have been stabilized. When they're better and they've been stabilized. Because when they're better and when they've been stabilized, that's when we can use these drugs to prevent the next GI bleed. Propranolol and nadolol are prophylactic. Propranolol and nadolol stop the next GI bleed. They don't do anything for anyone acutely. They stop the next GI bleed. It's like hydroxyurea in sickle cell disease. Doesn't do anything for you now, prevents the next sickle cell crisis. It's like cromolyn for an asthmatic. Doesn't do anything for you now, prevents the next sickle cell, it prevents the next asthma attack. Okay? It basically prevents the next one. It is prophylactic. The initial management of all GI bleeds, severe GI bleeds, fluids, blood, platelets, plasma. If your person is acutely bleeding, you want the platelet count to be above 50,000. Now, heme positive or guaiac positive brown stool. Heme positive or guaiac positive brown stool is essentially the equivalent of coffee ground emesis. In other words, all you need is 5 or 10 milliliters to have coffee ground emesis or heme positive brown stool. Melina, nice girl's name. How much do you need to get Melina? About 100 milliliters. But coffee ground emesis is a very small amount of blood. Etiology does not matter, not for initial fluid resuscitation. If it's gastritis or if it is ulcer disease, we will use proton pump inhibitors to help acutely stop the GI bleed. Proton pump inhibitors will not stop bleeding from lower GI bleeds. That is one of the only reasons to know acutely. The point of the nasogastric tube is one thing and one thing only, to know whether to scope from above or below. Lavaging out the stomach with iced saline doesn't help. Iced fluids in the stomach does not stop the bleeding. Anybody that thought they were told that the iced fluids would cause vasoconstriction, which stop bleeding, has been told wrong things. So therefore, it does not stop the acute bleeding. The only point of doing a nasogastric tube is if you are not sure if it's above or below. The other thing is, 32-year-old guy who's got a history of reflux disease. And he's got epigastric pain, and that epigastric pain is going up into the substernal area, and he's got a bad taste in his mouth, and he's got the whole thing that goes for reflux disease. His serology is positive for Helicobacter pylori. His breath test is positive for Helicobacter pylori. His stool antigen is positive for Helicobacter pylori. His breath test is positive for Helicobacter pylori. His serology is positive for Helicobacter pylori. Everything is positive for Helicobacter pylori. He's got reflux disease. What do you do about the Helicobacter pylori? The answer is nothing. Don't treat Helicobacter pylori unless there's gastritis or there's ulcer disease. Don't treat Helicobacter pylori unless there's gastritis or there's ulcer disease. Don't treat Helicobacter pylori unless there's gastritis or there's ulcer disease. Meaning, no matter how much Helicobacter pylori there is, reflux disease is not caused by Helicobacter pylori. Reflux disease is caused by too loose of a lower esophageal sphincter, allowing the acid to come backwards. Therefore, eradicating this organism is not going to tighten up your lower esophageal sphincter. Don't treat it unless there's ulcer disease. It doesn't stop your reflux to eradicate Helicobacter pylori. Your lower esophageal sphincter is too loose. That's the point. The biggest take-home message for people who have GI bleeding is nasogastric tubes don't solve it. Endoscopy doesn't solve it. Endoscopy solves it if you've done fluid resuscitation first. If you have a coagulopathy and you don't correct that coagulopathy, it doesn't matter how much you scope them. They're going to continue to bleed. So the first thing to do is to correct the coagulopathy. It's like a hole in your gas tank. Before you fill up the tank, doesn't matter how much you fill it up, you got to plug the hole in a way. And plugging the hole means correcting the platelets and correcting the coagulopathy. Let me tell you something that you may not remember when you're in the process of what you're doing in your preparations. Somebody is going to live or die someday based on how much you learned off of this tape. Because the mortality off those GI bleeds is 20% an episode. And if it's variceal bleed, it's 30 to 40% an episode. Out of every 3 people who have a variceal bleed, 1 dies. And they die more if you're sitting there scoping them when you should be giving fluids, blood, platelets, plasma, octreotide. What you're learning now is going to help somebody.